So here we go. Good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have one Dr. Sachin Wani with us. He is a consultant surgical oncologist, head and neck surgeon at HSG Vadodara. He did his surgical oncology residency at Tata Memorial Hospital, Mumbai. And he is IFH NOS fellowship in head and neck oncology. Has more than 20 years of experience, and his special expertise is in multidisciplinary treatment of head and neck and thyroid tumors. And he usually puts a lot of emphasis or special emphasis on rehabilitation part of the whole management of cancer patients. So welcome, Dr. Sachin. Thank you for agreeing to be our guest speaker. And thanks to Hemant also, Hemant Sant, who is our very old associate in Saturday Club of Baroda. He has been instrumental in getting few speakers recently. So thank you, Hemant, for that. And Sachin, you have about 40-45 minutes with you to talk, and we'll keep about 10 minutes for interactions also. So please go ahead. Thank you.
Sure, sir. Thank you for the introduction, sir. And thanks for giving this opportunity to present my work in front of you, sir. I'll share my screen. Am I visible, sir? My screen is visible.
Yes, very well visible.
So, good morning, all. Today's Saturday Club meeting, I'm going to talk about head and neck cancer surgery, a spotlight on head and neck cancer surgery. It is a very open topic for me, and I've taken liberty to present some of our work, our epidemiology, statistics, and how I see head and neck surgery. And I've taken nothing from any journal or any national international papers. So, what topics I would be covering in next 30 to 40 minutes would be I'll introduce my specialty because I still feel that it is not a very well-known specialty. Most of you know surgical oncology, oncosurgeon, ENT surgeon is a decade-old specialty. Head and neck surgery is none of them. And why this specialty is needed? Who can pursue this specialty? Again, this is not a very common knowledge in general that who all can pursue this specialty and what is the scope and work of this particular specialty. I'll also talk about different paths to become an head and neck surgeon. Maybe I'll share my journey from general surgeon to surgical oncology to head and neck surgeon. And then I'll come to my topic of organ specific in head and neck oncology, oral cancer. I'll talk about thyroid nodules management and some couple of slides on new tool in our armamentarium, that is image guided surgery. So I have some 80 slides. So let us see how far we can go. I'll start my presentation with about head and neck surgery areas of specialty. Head and neck branches off from surgical oncology and ENT surgery, as well as maxillofacial surgery. If oral oncology is very much part of head and neck, so even maxillofacial surgeon can ultimately become oral oncologist and practice head and neck. And broadly involves managing tumors arising in region above clavicle, excluding brain and cervical spine. 99% of our work is managing oral cancer, pharyngeal, laryngeal cancers, salivary gland tumors, thyroid and parathyroid nodules. So it is a complex anatomical region, as we know, with dense collection of nerves, blood vessels, muscles, sensory organs. Tumors in this region and also its treatment affects patients' core identity and individuality. Like if I talk about tongue cancer, the disease as well as treatment would affect speech, which is kind of identity of patient. All treatment related to head and neck region will have some scar left on the face. So it affects core identity and individuality of patient. Not only disease, but treatment also. And very important functions like breathing, swallowing, speaking, tasting, smelling are commonly affected. This is what we deal day-to-day basis. So for all this, you need a specialized team to manage all this. It just can't be operate and forget. It is a specialized care which can be delivered by a subspecialist along with his or her team. So usual journey of a patient goes like this in our branch. OPD consultation, investigation, counseling. We all know that this is what everybody does. Decision making. Most of our decision making happens through multidisciplinary team. I'll come to that. Decision making through MDT, execution, and coming back. Patient repeatedly comes back to MDT whenever there is certain decision has to be made. Once these basics are done, patient undergoes prehabilitation. Most of us know about rehabilitation, but in head and neck oncology, we start work of rehabilitation before patient starts any treatment, that is called as prehabilitation. We assess patients' basic function like speech, swallowing, taste sensation. Before starting treatment, we evaluate them. We try and explain them what to expect from the treatment. We try and make them understand what they will have to do during the journey of surgery, radiation, and how these functions will be influenced, and how we can one by one work on each of them. So prehabilitation is a big area where patient and his or her necessities are addressed. Then comes rehabilitation. Once during treatment, after treatment, this is an ongoing fight that to bring patient back to normal. The goal in oncology is now not just left to curing the cancer, but we want our patient to go back into the society and function as normal as possible. That is what rehabilitation does to the patient. And finally comes survivorship. Once a cancer patient is always a survivor, and survivors have a specific needs and problems associated with being a cancer survivor. So that those are taken care of. So as a surgical oncology, in my training, during early year of practice, what I focus mainly on first two. These three have subsequently come into patient care algorithm now, and this is where I find a role of organ specific practitioners. That is where why subspeciality and team building is important to take patient, give a individual care to patient. So prehabilitation, rehabilitation, survivorship is a learning process, and this learning is going to go on forever. So the team which I am talking about includes head and neck surgeon, surgical oncologist, reconstructive surgeon, medical oncologist, radiation oncologist, pathologist and radiologist, speech swallowing therapist, physiotherapist and nutritionist. I find all of us have an equal role to play in patient management. It is not that it is surgically driven work or a radiation oncologist driven work. If one of the piece is missing, I am sure somewhere down the line care is going to suffer. So the team and the team approach is very important in my area of work. So there are different pathways to become head and neck surgeon, head and neck cancer surgeon. Like a surgical oncologist, DNB, MCH, or a qualified surgical oncologist is a well qualified head and neck surgeon, and that is one of the most common paths to become head and neck surgeon. Then recently, 2 years back, DNB has introduced FNB fellowship in head and neck cancer surgery, which can be done after MS and DNB surgery or general surgery or ENT. It is a 2-year fellowship program, particularly in head and neck oncology. Now, there is also ongoing MCH program in head and neck oncology in institutes like Tata Memorial, Amrita, Kidwai, and couple of more institutes in the country. And there is one FHNO fellowship in head and neck surgery, which can be pursued after MS general surgery or ENT surgery and also by MDS maxillofacial surgeons who are interested in oral oncology. So at HCG Vadodara, we run two out of these programs. One is we do DNB surgical oncology training, and we have this FHNO fellowship program running for last 5 years. We have trained almost 4 or 5 head and neck surgeons who are practicing in different part of the country. So now coming to this is what all I wanted to talk about specialty called head and neck cancer surgery. Now coming to what surgeries we do, what organs we manage, and I'll briefly cover oral cancer, thyroid nodules, and a word or two about parathyroid diseases. So coming to oral cancer, I'm sure all of you are senior practitioners. India has the largest, you must be knowing, India has the largest number of oral cancer cases globally. Every third patient walking in our hospital, or for that matter, any cancer hospital in the region, is suffering from oral cancer. In SCG Vadodara, we see almost 1,000 to 1,200 new oral cancer patients every year. And unfortunately, still 75% are advanced stage, that is stage 3 or 4. And 1 out of 4 are upfront non-treatable inoperable, whom we could advise only palliative or supportive care treatments only. So, and in last 13 years of my medical practice and 8 years of our hospital, I'm not seeing this change in a very visible fashion. We still get most of our oral cancer patients in advanced stage. I think there is something missing about general knowledge, general clinical knowledge about this disease in community. Because as a cancer specialist, it is difficult for me to get an early oral cancer. So they have to come from community, and you clinicians who practice in community have certain responsibility to diagnose them early and maybe show them the right track. So this is a big missing link which I have observed in my practice, where we need to work together. So again, these are our statistics. Age distribution: 65% of our patients are in age group 41 to 60 years, and 1 out of 5 is younger than 40. What does it mean? That 80 to 85% of our patients are in prime of their lives. So this particular disease called oral cancer affects individual in his or her prime of their life. Most of them are young, working, sometimes only working member of the family. So we call that this is not a disease of individual, but it affects entire family. So oral cancer is kind of clinical diagnosis. You don't need any detailed imaging report or biopsy to say that certain lesion looks like oral cancer. Most of the time, they are clinically apparent. If you have seen 5 patients with oral cancer, the 6th one, when you see, you will be able to diagnose it. This is only cancer which can be clinically diagnosed by maybe all clinicians. You just don't need any special equipment, training, tools, or investigation. Maybe confirming diagnosis need biopsy, treatment planning needs a lot of things, but telling that this is oral cancer doesn't need any kind of training, except you must have seen 4 or 5. So biopsy, a tissue sample is removed surgically. Gold standard, and what we do is incisional biopsy under local anesthesia. That gives us 100% surety of certain lesion is oral cancer or not. The other options are brush biopsies. Now liquid biopsies are also being spoken about. They are mostly used for oral cancer screening, and at least not in a routine clinical practice. So why is staging of cancer is important? So whenever we talk about cancer, after diagnosis, staging is most important. What does it help? It helps in treatment planning, knowing prognosis, keeping audits, watching trends, participating in clinical trial, writing scientific papers. When I say that 75% of our patients of advanced oral cancer, that comes from staging. Whatever patient we see in our institute, we have staged them, and we have kept our audit of last 8 to 10 years, which tells us that every year we are seeing same trend. We wish that we see a trend where we see early oral cancer, but that is just not happening. So how does stage migration affect outcome? Why staging is important? Why staging is so often spoken word by oncologists? Because stage affects outcomes, and in particularly in oral cancer, the very kind of thumb rule sort of how stage migration affect outcome is like that. If a patient of tongue cancer, there are two patients of tongue cancer, same size, same age, same profile. One has a positive node, another has a negative node. One positive node in neck reduces survival 50% in oral cancer as compared to node negative status. Similarly, if there is a 3 centimeter plus node with extranodal extension, it further reduces survival by 50%. So, a small, so-called small migration in stage affects prognosis grossly by 50%. So 5-year survival rates by stage, certainly with advancing stage, 5-year survival in oropharynx or head and neck cancer deteriorates. So stage is one of the most important prognostic factor as far as survivals are concerned in oral cancer. Can every clinician stage oral cancer? Of course, yes. All you need is a pair of gloves and a torch. Oral cavity is easily accessible organ. Unlike breast, cervix, any other organ, GI, rectum, liver, gallbladder, lungs, brain, oral cancer is easily accessible organ. All you need is a pair of gloves and a torch to diagnose oral cancer and stage oral cancer. I am sure even a pediatrician can stage oral cancer. It is simplicity has been responsible for its widespread adoption in clinical practice. So I appeal to all of you that start doing this. This is really a cancer with epidemic proportion in our country. So every clinician should be capable of diagnosing oral cancer, diagnosing early oral cancer, staging upfront. All you need is a 2 minute of thought process and maybe some understanding how oral cancer is staged, and you are able to do that. You don't need MRI, you don't need PET scan, you don't need CT scan. They are staged clinically. So yes, every clinician can stage oral cancer, and it being easily accessible organ, which is not true with breast, cervix, or any other organ. So TNM classification has been widely used all around the world to plan treatment, to estimate prognosis, and evaluate treatment results. And it is very simple. Gross staging is not very difficult. Differentiating between early oral cancer and advanced oral cancer is not difficult. What we currently follow is was published in 2017. So this is a TNM staging which is universally used for staging oral cancer. So for generalist, maybe clinical staging is all you need to know. So stage mainly depends upon size of the tumor. You don't need a scale, it is a guesstimate, and involvement of skin, involvement of underlying bone. If skin or bone is involved, then it becomes stage 4. If it is a superficial tumor with less than 2 centimeter, then it is T1. If it is infiltrative tumor, it looks deeply infiltrative into tissue like buccal mucosa, tongue with depth more than 1 centimeter, then it becomes stage 3 and it goes into advanced oral cancer. So it is not difficult to guesstimate that how big a tumor is, how infiltrative it is. And any palpable node which is hard, is considered positive node clinically. So any positive clinical node puts patient into advanced oral cancer bracket. Anyway, disease is advanced, but if treatment is offered early, certainly it will ultimately convert into cure. So what are our treatment goals when we talk about oral cancer? Whenever patient of oral cancer is treated, the treatment of primary and neck, that is cancer control. It is always primary and neck. The smallest of lesion, the smallest of primary, the neck is always treated. And there is a wonderful paper by Professor Anil D'Cruz, which actually guided the world in management of neck in oral cancer. That was a randomized control trial which was published in NEJM 2012. After that, we and rest of the world know that neck management is an important part of oral cancer management. And whatever the size, whatever the depth of the tumor is, neck always needs management. Second important goal is preventing recurrence. That is avoiding second primary, early detection of recurrence and second primary. Now, once a patient is treated with oral cancer, 30% of them will come back with second primary in oral cavity itself. Because it is not that even patient would have stopped all habits, but the mucosal changes which have happened because of previous exposure doesn't go away like that. So patient is at risk of having a recurrent ulcer or disease in oral cavities upwards of 30%. So preventing recurrence, by preventing I mean early diagnosis of recurrence and treating them. We have dozens of patients whom we have treated, operated for 4 times, 5 times, because we follow a very strict survivorship program. All our patients of oral cancer have a regular program of visiting us. We do routine clinical examination. We are very we don't think twice before advising them biopsies if there is any suspicious lesion. And whenever there is a very small recurrence, we are able to salvage them. So our salvage rates are good just because we have a very good survivorship program. So early diagnosis of recurrence is a very important treatment goal in oral cancer. Now comes preserving organ and preserving function. That is something new. New means at least 10 to 20-year-old story. Maybe when I was a trainee in Tata Memorial, all we were talking about was that patient is cancer free. In follow-up OPD, all I would write in my notes is clinically NED. So that is not enough. We want a patient who is able to function. So from there, from that goal comes preserving organ and preserving function. Nowadays, when we Nowadays, when we treat a patient of head and neck cancer, oral cancer, we always think about how the patient's function will be after treatment. So there are multiple approaches like mandible preservation approach, where sometimes patient is treated with neoadjuvant chemotherapy and then operated so that mandible can be preserved. Tongue preservation is another important goal. Again, with the help of neoadjuvant chemotherapy, we are able to do that. So preserving organ and preserving function. Few of head and neck cancers which were conventionally treated with surgery for decades have now gone out of surgical purview and organ because of organ preservation protocols in place. For example, laryngeal cancer. There was a time when the only treatment of laryngeal cancer was surgery. That is laryngectomy. Patient would lose his or her voice forever. But now most of the patients go for chemoradiation or sometimes chemotherapy followed by radiation, which is an organ preserving protocol for laryngeal cancer, laryngeal and hypopharyngeal cancer. Then last but not least, and my favorite area of work is rehabilitation, where patient speech, swallowing, social, psychological, all aspects of patient's life needs to be rehabilitated, and it is a continuous work of a clinician. Any difficulty, any maneuver with patient can be helped, and you don't have any magical pill that patient starts swallowing after tongue cancer surgery. So it is a gradual work where patient progresses from liquid diet to maybe thicker liquid to soft diet to maybe at best soft diet. So this is a gradual progress and it needs a lot of work. So choice of treatment in oral cancer, the general principles are stage 1 and 2 are treated with single modality, which is effective and it is preferable also. Stage 3 and stage 4 are multimodality, becomes essential. Why single modality is preferable? Every modality of cancer management brings sets of complication along with it. So it is always preferable for patient that he or she is treated with single modality. And that in oral cancer it is possible in stage 1 and 2. Most of them are upfront operated and they have a chances of cure are in range of 80 to 90%. If patient is diagnosed in stage 1 or 2, he or she doesn't need any chemotherapy or radiation. I tell you, there is a huge difference between quality of life of a tongue cancer patient who has been operated and observed and another patient who has been operated and radiated. The entire life changes once multimodality comes into picture. So, as a goal of my life, I want to see more and more stage 1 and stage 2 patient because we don't want our patient to suffer a lot. We don't want our most of our patient to have recurrences. So stage 1 and stage 2 are ideal patients to treat. They have a good survival. Most of them are treated with only surgery. Stage 3 and 4, multimodality becomes essential. So a single modality for early stage, most of the time is surgery. And when it is advanced cancer, then permutation combination of all three is required. 10 to 15% of our patient presenting in advanced stage, where we can't operate them upfront, we treat them with neoadjuvant chemotherapy, where 2 or 3 cycles of chemotherapy are given. After that, there is certain downstaging of cancer, which helps us to perform surgery and at least remove his cancer physically and treat with adjuvant treatment. But you know what? Even after this long exercise, the survival of patient depends upon his presentation stage. If patient has presented at the stage 4, you may give chemotherapy, you may downstage the disease, you may operate, everything is fine. But the prognosis of patient will be dependent upon stage on presentation, that is stage 4. So coming to imaging in oral cavity cancer, it is essential for to understand deep extent and bone involvement. It is superior to palpation and lymph node assessment. Most of our patient, CT scan is a workhorse. MRI we do for specific questions like perineural invasion, medullary bone invasion. PET scan is generally not done in oral cancer patient when they come for the first time. It is a tool which add very little value in primary assessment of oral cancer. There are certain indications like recurrent cancers, post-treatment failures are the patient where PET scan becomes mandatory. So knowledge of anatomy with understanding of common routes of spread allows radiologists to accurately determine disease extent and help clinician to plan appropriate therapy. See, this is where radiologist becomes a very important clinician in our team. When we discuss patient preoperatively in our tumor board, we eat up their heads to understand. Please tell us the finer points which we need to know at the time of operating the patient. We need to understand where the cancer is spreading, what is the depth, any surprises we expect on the table. So radiologist has got a very important role. It is like performing a virtual surgery. The discussing patient imaging with radiologists in multidisciplinary team is like performing a virtual surgery before you actually take patient up for the surgery. So there are finer points. The small lesion in retromolar trigone area of oral cavity would have spread in any of the dimension. It would have spread to base of tongue, which may not be clinically apparent. It would have spread into infratemporal fossa region of the skull base. Sometimes these patients might become inoperable in view of infratemporal spread. So this is where CT scan or imaging or a radiologist role is very, very important when we manage oral cancer patient. And we are very uncomfortable taking our patient up without discussing the CT scan with radiologist in their suite or in MDT. So for tongue cancer, normally MRI is done, which has a better resolution of soft tissue as compared to tongue. You can clearly see gray and white differentiation, and this helps us take the third dimension. The involved muscles are seen one by one, and they can be identified intraoperatively and can be taken in when you have a good MRI report with you. Now, coming to surgical management of oral cavity cancer, maybe a brief talk about it. I would just show you some clinical pictures of a patient, what type of surgery is done when, and a brief word about reconstruction. So, extent of surgery in oral cancer is simple wide excision of oral cavity cancer without any reconstruction, to composite resection with microvascular reconstruction and long rehabilitation. So it is a wide extent of surgical operations we perform for oral cancer. Now, briefly coming on to one by one, this is a T2 tumor of right lateral border of tongue. This patient would be managed with a type 2 glossectomy, where we take at least a centimeter of margin away from the lesion. We confirm our margins on frozen section that we have done an adequate job. Then simultaneously, although patient doesn't have any lymph node in the neck, his CT scan doesn't show any lymph node in the neck, but T2 tongue cancer, there are more than 30% chances of failure in neck in near future. So we would do a modified neck dissection for this patient. This is another verrucous lesion. I just wanted to show you some pictures so that maybe they stays in your mind, and if you see a next oral cancer patient, you suspect it to be oral cancer, and maybe patient will be diagnosed in early stage. So this is a small white ulcer, angle of mouth, chronic tobacco user. We biopsied it. It is invasive cancer. Again, as you see, I have marked with the help of a scale. We do this marking. We just don't take it just like that. With the help of scale, I have marked 1 centimeter all around, and this will be excised along with the skin, because if you see the tumor, the third dimension of tumor won't be very away from the skin, so the entire lesion will be excised with the skin. Again, we will do a neck dissection for it. Now, coming to the advanced cancer, patient has got a retromolar trigon lesion, which I was talking about in describing the CT scan. So retromolar trigon is a very it is a small triangular region in the posterior aspect of buccal mucosa, and a very scary place to have a tumor in. Whenever we see a lesion in retromolar trigon, we are always worried that it must have spread in one of the possibilities. So we would have imaged him, and the resection also is most of the time a composite resection. Even if a small lesion, we have to take part of the mandible, we have to take part of the maxillary bone, that is alveolus, part of the base tongue, and do a composite resection so that we get a clear 3 dimension. See, margins, a good operation is the only prognostic factor which is in our hand. Patient visiting to us after 6 months is beyond us. Tumor biology is beyond us. Patient not going for adjuvant treatment out of any reason is again beyond us. But giving a good surgical treatment, doing a good composite resection, keeping good margin, a proper and adequate operation is the only prognostic factor which is in surgeon's hand. So another lesion, the posterior aspect of tongue. So once disease is extending on the posterior aspect of tongue, the surgery becomes more complicated, more complex. These tumors are addressed not through oral cavity but through neck. We have a habit and practice of doing a pull-through glossectomy. Pull-through glossectomy is a very popular technique of doing a tongue resection, considering hemi-tongue as a compartment. So when we operate on this lesion, we tend to take hemi-tongue along with all floor of mouth muscles, along with its blood supply, along with its nerve supply as a compartment. So ultimately, that converts into better survival. And this is not a common practice across the world, but yes, good institutes do this practice of doing compartment dissection in head and neck cancer, tongue, buccal mucosa. Even for retromolar trigon, we do a compartment dissection. We always tend to remove infratemporal fossa. Anyway, the muscles become useless if you remove it partly. So we tend to remove entire compartment of infratemporal fossa or masseteric space whenever there is involvement there. So this is another tumor where it was in buccal mucosa retromolar trigon. Again, although it is not involving mandible, the location and size of the tumor demand a radical operation. So patient would need a mandible management, maxillary management, followed by reconstruction. So coming to reconstruction, I'll just skip a couple of slides and come to reconstruction. So reconstruction in oral cavity cancer. What in my 20 years of practice, what has radically changed in oral cancer care is reconstruction. When I was in private practice 10 years back, reconstruction facilities, the results were okay, not very good. But now when you see our reconstructive surgical team performs multiple flaps in one patient, and our flap survival rates are more than 97%. So reconstruction has really helped resection surgeon. I call myself an ablative surgeon in a way that I don't have to worry when I do my ablative operation that reconstruction can't be done, because I have full confidence in my reconstruction team that whatever defect I give them, they will be able to put a flap and give a good quality of life to my patient. So again, I will show you a few pictures. So what are the goal of reconstruction head and neck? It is to achieve integrity and continuity, to augment function, improve cosmesis, prevent trismus, achieve competence, support tongue and larynx, which allows function. So each of them is a very important goal of reconstruction, and each of them is been considered when you decide what type of reconstruction you will do in what type of patient. So again, this is a multidisciplinary management. When plastic surgeon is available to me at the time of seeing patient clinically and deciding the treatment plan, that makes our life little comfortable. He understands what I am going to remove, and I know what he is able to do. So types of flap we do are local pedicle flap, pectoralis major myocutaneous flap, nasolabial flap, ascender flap, local rotation flap. And three major microvascular surgeries we do are free radial artery flaps, free anterolateral thigh flap, and free fibular flaps. So these are workforce of our head and neck reconstruction. More than 90% of head and neck cancer, oral cancer patient particularly, would need some type of reconstruction, because whenever tissue is lost, it is always to borrow the tissue from somewhere and bring it back and fill the defect. That ultimately gives a better cosmetic and functional outcome. So there are different types of flap we do for our oral cavity reconstruction. One common flap is free anterolateral thigh flap. Another, again a very workhorse for tongue cancer reconstruction, is free radial artery forearm flap. So these are pictures of patient. They are our cancer survivors, and we are happy that after 8 years of surgery and treatment, they are functioning. Yesterday, I saw a patient who is in police force. So when he came for follow-up, our receptionist asked him, "Bhai, patient kahan hai?" He said, "I am the patient." So these are the small joys of our practice. So these are some results of our outcomes and pictures of some survivors. This patient has undergone a free fibula flap. This one is free radial flap for angle of mouth reconstruction. This is another patient with angle of mouth reconstruction for lower lip defect. These are our patients operated for mandibulectomy followed by reconstruction, both of them. So this is a picture of fibula flap, which is very important flap for bone defect, that is jaw defect. Most of the time mandible and few occasions maxilla also. So maybe 10 years back, this patient would not have come to operation theatre. I am sure. But now we are confident. Even such patient can be offered a comfortable ablative operation, radical operation, where you remove the tumor with safe margin along with mandible and can be reconstructed with dual flap. This patient has undergone a fibula flap over anterolateral thigh flap and is functioning reasonably okay. So thank you. I think I have already taken 45 minutes. So we can call it a day for today, and maybe for thyroid and parathyroid tumors, I'll request my colleague to have another presentation. Is it okay, sir?
Yeah, but you still have some 5-7 minutes if you want.
Maybe some question
Because
answers if there are,
it's
sir. So
43, so
if I start, it will take 20 more minutes, sir.
okay, okay. And then let us stop it. So you can stop the screen sharing, then
Sure,
we'll
sir.
have some discussion. So thank you, Dr. Sachin, for an excellent presentation. The whole presentation as a pediatrician and moderator of this group, I believe is full of passion. I mean, the way you started in a simplified manner as to introduce as to what head and neck surgery is all about. And then you built up to a very complex case as you in your last slide showed. It reflects the passion with which you work. So thank you very much for sharing your work. And
Thank
it
you.
was actually very beneficial to know for all of us that we being non-surgical clinicians also can sort of contribute to the early detection of these oral cancers. So thank you for sharing all the nice information. Now the house is open for discussion, comments, question. Yes. Jagdish bhai? Yes.
Yeah. Dr. Sachin,
Yes, sir.
most of the oral cancers, do they come from lower socioeconomic group?
So that is true with in general our country. But in Gujarat, it is not the case, sir.
Okay.
We see CEOs of company coming with oral cancer. That is very unique about epidemiology of oral cancer in state of Gujarat.
Because of Gutka? Because of Gutka?
Because of Gutka, sir, Gutka being a social norm.
Okay.
If you see in maybe Maharashtra or neighboring state, what sir said is correct. Most of the patient would come from low socioeconomic strata. But here we have all sort of people coming in Mercedes and BMW with oral cancer, sir.
Do you give radiation and chemo before doing major surgery in complex cases?
In oral cancer, still there is no relevant role of neoadjuvant therapy.
Okay.
Certainly not radiation. 15% of our patients we treat with neoadjuvant chemotherapy, where we are able to downstage the cancer. Only in the cases where we are unable to do upfront operation.
Your reconstruction team attends the surgery while you are doing it?
Any reconstruction team, sir? Pardon me.
Your reconstruction team is a
Yeah,
part of operating team?
yeah, very much part of operating team, sir.
Okay.
Now today I am doing a tongue cancer. My reconstruction team, Dr. Yogesh Bhatt, will simultaneously start taking the flap.
Okay.
So we work together. We work in two teams. I am in the head and neck side of the table. He is on the anterolateral side, his thigh side of the table. And by the time I finish my resection, his flap, we save time also in that.
Which artery is used for vascular anastomosis?
So in neck region, most commonly used vessel is facial arteries and intrajugular vein. And in patients, as I said, almost 20% of our patients are recurrent cancers where facial has already been used or sacrificed. In such patient, we do either superior thyroid vessels or sometimes lingual artery.
Dr. Kiran has put a question in the chat box. Is there anything to offer for those who lost 90% of tongue function after therapy?
If once treatment is done, all we can do is rehabilitating the patient by understanding the speech and swallowing difficulty he is facing. So we have certain exercises, certain therapeutics which can be given to the patient with the help of which his speech may improve a little bit and swallowing can be worked on. Our main focus area would be on swallowing so that at least patient is not aspirating and not losing weight and simultaneously on speech. But when patient loses 90% of natural tongue, whatever type of plastic surgery do, it is not going to compensate for natural tongue. The function of the tongue mainly comes from native tongue, not from our flaps. Flap would add bulk. It will just help natural tongue to do its function better.
Dr. Rajiv is there. Rajiv, would you like to offer some comments?
Hi, morning. Thank you, Satish. No, I think Sachin has very nicely and concisely presented, the problems and the challenges we face in treating head and neck cancer patients. And like he said, for tongue cancers, essentially functional rehabilitation becomes the key. And we structure our reconstructions to optimize function of the remnant tongue. This is generally the focus because unfortunately, as of now, medical science hasn't been able to produce an artificial tongue. I have a lot of patients who ask Sachin that isn't there an artificial tongue available that you can suture and can function like a tongue, But unfortunately, that isn't the case. And the saddest part of this entire thing in head and neck cancer is that this is a generally preventable cancer. And this is what actually pains all of us who are seeing these cancers. We see young people, families losing livelihood. So all this is a major problem. But I think very nicely he has highlighted. Thank you, Satish, for giving him the opportunity to be able to share this with the class.
Thank you, Rajiv. I have one question for you and Sachin both. I mean, you being heading a very big and very reputed HSCG as a cancer hospital. What as a society we can do to prevent these advertisements, of gutkas by very great celebrities? I mean, when sports person also are seen doing it, it hurts actually. So, like your society, are you doing anything for that?
Okay, I'll ask Sachin to take this.
Sir, after being in this work for almost 2 decades, I understand that either I can be a masiha for people and work in tobacco cessation, or I do my clinical work as a cancer surgeon.
Very
I can't do both.
Right.
I
asked about as a society, like say IAP, Indian Academy of Pediatrics, we take up a lot of issues of advocacy with the government authorities. We take up cudgels with the courts also on certain issues. So is Cancer Society doing something?
We do run sedation clinics, sir, unfortunately, which has not picked up. Even in my OPD, I ask my patient to go and see a psychologist. They would just go out of the door. They wouldn't go and see a psychologist. So where is the problem and how to solve? I am still struggling to figure out, sir.
Okay.
Yeah, I think Satish, I'll just quickly add to what he has said. Specifically answering your question. A lot of work in this regard for patient advocacy has been done by Dr. Pankaj Chaturvedi. You might have heard the name. He was head of the head and neck oncology at Tata Memorial. And he's done a huge amount of work. And in fact, they've filed legal cases and public interest litigations and all of that stuff, with the result that now the ads that you're seeing on TV and films, which are quite offensive ads, are the direct result of that advocacy.
Right.
So, but it has limited impact. I mean, at the end of that, when you analyze the effect after 10 years in society as a whole, unfortunately, tobacco consumption has reduced, yes, but not very significantly. And the main reason is that, it provides livelihood to a lot of farmers in our country. It is a major source of revenue, not only for farmers, for the government. We are, I think, the second or the third largest exporter of tobacco in the world. So this is not something easy that you can actually, wish away under the carpet. So at the end of that, I remember at one of our last conferences, one of the key things was that even if you can get to a stage migration, if we can move the presentation from 3-4 to 1-2, that also will be a big thing. And I think this is where societies can help, that you have an increased level. If you get an ulcer that hasn't healed in 3 weeks, go see a oral oncologist.
Right. Thank you. Thank you, Rajiv.
Satish bhai,
Yes.
I was with Rajiv's team HCG and I was given work for preventive oncology. And lot of preventive oncology talks we have reached, touched all the industries around central Gujarat and villages and Lions Club, and showed them what Rajiv said. At least diagnose the cancer early and what are the dangers of gutkhas and all that. And on that time, we can easily, Advertisement Council of India, you can online simply take a photograph of that and send it to the Advertisement Council of India. This is an unhealthy ad. So that I used to do for tobacco, and even Patanjali stall claims in COVID. So all doctors can do that. Just mail it to Advertisement Council of India or write a letter to editor or whatever Lions or NGO group they are. So preventive oncology is very much active across India. While the clinicians are doing their work, and two things which have changed in operation theatre, which I found as a part of HCG, was a microscope in the operation theatre for a fine reconstruction. But most important was the frozen section machine, which is available to our team of surgeons everywhere, and especially what I saw in hospital where I work in HCG, that science guides, the science of pathology guides the extent of resection, and then the radiotherapy or whatever therapy joins in, and the other team of rehabilitation joins in to make life easier.
Thank you, Dr. Hemant, for those comments. Are there any more comments or questions? Okay. So if there are none, it's time we end the session here. Once again, thank you, Dr. Sachin, for being our guest speaker. It was really very informative and useful. And thank you, audience, for the interactive session. Thank you all. We meet next.
Thank you for the opportunity.
Thank you.